Thanks for talking to me today. Can I just ask you to introduce yourself?
Yeah, my name's Elspeth Aspinall, and I'm a GP in Grampian, and one of the roles I have is the primary care cancer lead.
We're covering up GI cancers today. Can you just tell me what cancers are included in there?
This is a renaming, and the cancers included are esophageal gastric, stomach, pancreatic, gallbladder, and liver.
What are the key changes to the guidelines?
The key changes are that the referral criteria have been redefined, and there is removal of some standalone symptoms such as vomiting, painful swallowing, iron deficiency anemia, and there have been the addition of a new age threshold of 40 years plus for jaundice, and there is an addition of advice about clusters, combinations of symptoms, which together will raise the positive predictive value above the threshold of 3%, whereas the standalone symptoms do not. Furthermore, there is recognition that these cancers can present with really quite vague, non-specific presentations, which in themselves have poor predictive values. And some of these cancers may well be appropriate for pathways such as direct to CT or rapid cancer diagnostic services where available.
Is there a problem with late diagnoses in all of these pathways?
These cancers, unfortunately, are particularly associated with late diagnosis, in particular pancreatic. In pancreatic cancer, just over 53% of patients, unfortunately, are diagnosed already at stage 4 of their disease.
Can we talk about the risk factors for all of these types of cancers? We do esophageal gastric first.
For esophageal gastric cancer, as with many cancers, increasing age is a risk factor, as is obesity. Men are twice as likely to be diagnosed with this as women. If there's a family history, this raises the suspicion, in particular family history of esophageal gastric cancer. Again, a common theme in the referral guidelines is lower socioeconomic status, deprivation, raising the threshold of suspicion. Smoking, alcohol excess, chronic esophageal reflux, and Barrett's esophagus also increase the risk of these cancers.
And what about the hepatobiliary and pancreatic cancers?
Age over 40 is an increased risk factor, and in particular, there's a big rise in incidence over the age of 60. Smoking, again, alcohol excess, and a history of chronic pancreatitis is also known to be a risk factor. A history of chronic liver disease and viral hepatitis. Hemochromatosis is a risk factor, as well as a family history of liver cancer.
Are there any investigations that we should be arranging in primary care prior to referral?
Yes, so the assessment section advises an abdominal examination, and whilst this might sound like a common sense, straightforward thing to do, I think it is important to state it because primary care has changed, and there is a shift. We all know there's a lot more telephone and remote digital consultations going. So just that reminder to put a hand on the patient's tummy and examine them. Blood tests, so an HbA1c, if there's a new diagnosis of type 2 diabetes, then that could increase the likelihood of pancreatic cancer. We've known that already. Other blood tests to exclude anemia, whilst it's not an individual reason for referral, iron deficiency anemia would add to the burden of evidence pointing to a cancer diagnosis. High platelets, thrombocytosis is in particular associated with this group, but can be other cancers. So again, it's important to think about overlap with other cancers, and renal function and liver function is also advocated.
And presumably you wouldn't, would you be referring directly for gastroscopy on these patients?
The secondary care colleagues that we refer to will decide, based on the individual patient presentation, what is the most appropriate assessment to have. So that may well be an endoscopy, that may well be a CT scan, or it could well be an ultrasound scan. But it's important not to be too specific with what exactly the investigation is that the patient will receive, because we don't know exactly until that patient is seen in secondary care. It's important to tell a patient that it is an urgent suspected cancer pathway. As with all the pathways, patients can get understandably disturbed and upset if they receive information from secondary care saying that they have been referred along a cancer pathway, and if that word cancer hasn't been mentioned, that can be a cause of concern. So it's important that they know that it is an urgent suspected cancer pathway. So advice that the referral is a suspected cancer pathway, and the secondary care clinicians will assess and advise what the next steps are.